يا من صليت بكل الأنبياء.
Hey, assalamu alaikum, everyone. Thank you so much for coming out, and thank you for the conference for inviting me. I'm already a little anxious because I did not intend for my name to be so huge and for the title to be so small. So I'm praying that the slides are exactly as I submitted them. That does not inspire a lot of confidence. I was going for a plant theme for the slides. Some of the slides have a couple corny pictures. Please forgive me. Don't focus on that. Focus on more of the content of what I'm going to share with you today. I'm going to start off by saying that I love treating psychosis. I think it's the most fascinating of the areas of mental health disorders. It is one of the most misunderstood and one of the most stigmatized mental health disorders out there. I also come from a perspective of not only a psychiatrist, but also I'm a family member. I have a family member, a loved one who has schizophrenia himself. And that has definitely informed my approach to things, my approach to psychiatry, my approach to caring for young people with psychotic disorders. So understand that I come from this from a dual perspective. So yeah, no financial disclosures to report. All right, so in terms of an agenda, I do have a few objectives I have to get through. I'm going to try my best to fit them all. So basically, I'm going to talk about epidemiology and diagnosis of certain psychotic disorders. I'm going to talk to you about the etiology as best as we understand, because we don't totally have a full understanding yet. And that's true really for all mental illnesses. We're going to talk about family intervention, and I think that this is a really key part of the talk. And as mentioned, I invited my mom to come here, so we have quite a personal aspect to this. I actually asked that part not be recorded. I think it will be recorded, but not disclosed, just because I want to respect my family members' privacy. So you're in for a treat that you get to hear about our own experience. All right, psychosis. So when I think about psychosis, what does that mean? What does that term mean? For me, the hallmark feature of psychotic disorders or psychosis is reality testing or having a hard time telling what is real and what is not. Like that, to me, almost all of the symptoms involved in psychosis are rooted in that. So when you think of psychosis, you might think of hearing things that aren't there, seeing things that aren't there, feeling paranoid, the belief that someone or a group of people are after you. That is all rooted in what that individual feels is real. Other people are telling them that it's not. And I really want to highlight here, and I said this at the previous talk, I am here. I like to think I'm here. I'm present in this room. I'm seeing all of your faces. If someone were to tell me that my experience here isn't real, that what I'm seeing isn't here, and the things that I'm hearing aren't there, I would be pretty offended. I would feel quite defensive. So I always remind myself when I'm approaching someone who has a psychotic illness, is telling them what they're hearing and seeing is not real. And actually, I don't even do that. I don't even do that. I'd much rather focus on their experience and how to help them. So I want to impart upon you that that is the core of this condition, of these conditions. Okay, so core clinical features, meaning core symptoms. Delusions, these are known as fixed false beliefs. It is commonly things like the police are following me, are watching me, CIA, FBI, those are some common examples. I'll talk about this later, but for the Muslim populations, it can include that they are one with God, that they are hearing God. Sometimes for them, they're another prophet. So to them, that's a fixed false belief, okay? Hallucinations. Hopefully many of you have heard this term before. It's often auditory hallucinations, so hearing things, hearing voices. And when you ask them, do you hear it from the outside or from within your own mind? Because we all can have our own mind's ear, right? If you want to hear a song in your head, you can play it in your head, right? That's in your auditory cortex. There is capacity for us to do that. But no, for them, it's as if it's coming from the outside. Now, I emphasize auditory hallucinations because, and I'll talk about this later, it helps differentiate psychosis like schizophrenia versus psychosis from a medical condition, another medical condition. But truth be told, hallucinations can be from all of our five senses. So feeling things, obviously hearing and seeing. It can be taste, but classically it's auditory. Thought disorganization. So that's another feature. And to me, thought disorganization leads to behavioral disorganization and disordered speech, disorganized speech. But it's all rooted in their thoughts are disorganized, right? So doing things repetitively that don't make sense. I remember my loved one, I don't know if my mom remembered this, but I remember when really early on in his illness, he would sometimes be kind of preoccupied and taking a bottle of water and just pouring it on his hand. Like, what does that mean? Like, to us, that was disorganized, didn't really make sense, but to him, it meant something. Negative symptoms. Let's go back. Negative symptoms. So what I talked to you earlier were delusions, hallucinations, thought disorganization. Those are known as positive symptoms because an outsider can also gather, like we can't hear what they're hearing, but we can see them laughing to themselves or maybe outright talking back to the voices that they hear. So I think of positive symptoms like the things that I can observe as an outside observer that there may be psychosis at play. Their speech is disorganized. They're talking about their delusions. Negative symptoms, though, they're the ones that don't get a lot of attention, but I would say equally, if not more important, especially after treatment's been initiated and those positive symptoms improve, the negative symptoms are difficult to deal with. And what do I mean? I mean amotivation, lacking motivation. I mean hygiene, taking proper care of oneself. Alogia, or absence of speech, poverty of thought. Those are also negative symptoms. There are also neurocognitive features that I think are much less understood in psychosis. Almost every patient that I see, young patients that I see with this illness, school or work has been impacted in some way. Part of it is because of those positive symptoms, but part of it is also the difficulty with attention and working memory. That part is a lot less understood, and I look forward to future research on that. So when we think about causes of psychosis, I think of it as not so much the cause of psychosis, like what is causing the hearing things. I mean more like this umbrella term of psychosis. What are the things that fall under that? And I think of three categories. Primary psychotic disorders, that's what we classically think of, right? Schizophrenia, bipolar disorder, schizoaffective disorder, schizophrenophone disorder, substance-induced psychosis. I'm not going to go through all of those. I will a little bit later. But those are what we call primary psychotic disorders, meaning that whether substances are involved, whether there's another health condition, this person has this psychotic illness independent of those things. So those are what we classically think of. But we also have to consider things like psychosis due to another medical condition. So again, I'm not going to go through all of them. There are many of them, but a lot of physical health conditions can manifest with psychosis symptoms. This is true for mood and anxiety as well. So let's say someone has a condition that results in taking a medication that are high dose steroids. High dose steroids can cause people to raise their heart rate, raise their blood pressure, racing thoughts, and can lead to things like hearing things. And then when the steroids are taken away, the psychosis experience goes away. So that's just one example. Brain tumors, certain brain tumors in certain parts of the brain may cause some of those psychosis symptoms too. So if that cancer is treated, that psychosis will go away, ideally. Substance-induced psychosis, this is super important. And I also acknowledge that in our faith, in our community, I shouldn't say our faith, but in our community, substances has its own sort of stigmatized aspect because we come from an abstinence-based approach from a religious perspective, right? But truth be told, I'm going to be honest, and I'm sure many of you know, just because we're told not to, doesn't mean that people don't use substances. I always approach all my Muslim patients, I always ask them, and sometimes they say, no, absolutely not. And I'm like, I still ask because some of my patients do. So substance-induced psychosis, common ones being cannabis. Like hopefully people are nodding when they hear this because we're just short of saying that there's a causal link between cannabis use and schizophrenia. Lots of people will use cannabis. Not everyone will have psychosis, but some will, and especially if they have family history of psychosis. But I want to also flag that substance-induced psychosis means true substance-induced psychosis, meaning they don't actually have a primary psychotic disorder, that they should only have psychosis in the context of the use and withdrawal and a short term around the use of their drugs. So if they truly have a substance-induced psychosis, stopping that drug should ideally mean that they recover and they don't have psychosis. But unfortunately, for some people, the psychosis persists. And the way that we conceptualize that is they likely already had an underlying psychotic illness like schizophrenia that would just unveiled itself through the cannabis use. As an example, of course, there are other substances like stimulants, cocaine, crack being common ones. I really wanted to share a little public service announcement from, if I may. I'm here on my pulpit, to say, from the mimbar in a mosque, to say, please stop describing people or things as psychotic. Please, please, please. It is so commonly used. There's a lot of discussion about we shouldn't be using the word crazy, because there are people who have mental illnesses, being very careful of our language. I have a particularly sensitive spot about psychosis because these are the patients that I serve. I have a loved one with a psychotic illness. So when I hear someone say, my boss, she's so psychotic, I'm like, well, there are people who actually have these conditions who are trying so hard and want to get treatment, want to take care of themselves, but there's so much social stigma. So we actually contribute to that stigma by using those terms to describe people who don't actually have psychotic illnesses. Epidemiology, etiology, and diagnosis. So epidemiology, I'm going to fly through this because I want to make sure we're getting through the presentation. I really want to involve my mom. So epidemiology, thinking about incidence. To remind ourselves, incidence is the number of new cases relative to the population at risk. So not the entire population, but the population at risk over a specific period of time. In this case, I'm doing per year. So when we think about psychosis, so forget whether it's schizophrenia, bipolar disorder, from a medical condition, whatever it's from, just the psychosis experience, worldwide, 50 per 100,000 per year. Schizophrenia, if we think of a classic example of these conditions, schizophrenia, I would say is a classic. The worldwide incidence is 15 per 100,000 per year. Canada they did it per 1,000 at 50 per 1,000. I actually wanted to highlight this. I always consider worldwide always an underrepresentation of the true value because there are so many countries in the world that are not capturing this data. So see how Canada is 50 to 1,000 and worldwide is 15 to 100,000. That's a huge disparity. And to me, the way I understand it is we are capturing it better here in Canada through data than other places are in the world. Prevalence. Prevalence is the total number of existing cases, both new and old, right? So different from incidence, which is new cases, over the entire population. So irrespective of whether the person's at risk or not, over a specific period. So again, I'm going to go through this quickly. Psychosis worldwide, 4 in 1,000 in 12 months. 7.5 per 1,000 in lifetime. Something I really wanted to emphasize as a takeaway point for you is 13 to 23% of people, this is worldwide, experience psychotic symptoms at some point in their lifetime, but only 1 to 4% will meet criteria for a psychotic disorder. Isn't that fascinating? So there are a lot of people who will have these experiences, but it doesn't necessarily mean that they will have a primary psychotic disorder. It might be because they stopped the drug that was causing the psychosis for them, or they had a health condition that was causing the psychosis, and that health condition has been treated to remission. Or not. Some people just hear things and have an episode and never have an episode again in the future. All right, etiology. Let's think through factors that help differentiate between medical versus psychiatric causes of psychosis. I think of rate of onset. So if someone was doing well and there were no signs or symptoms, and very quickly over the course of a few days or under a couple of weeks, there's really rapid onset and it's pretty intense and severe, that is going to make me think more of a medical cause. So something physical, that might be causing this. Because if it is more, you take a history and you delve through and you realize that actually for a couple of years before this episode, there was social withdrawal, there was some mood symptoms, there was some anxiety, there were some things that seemed a little bit bizarre, but then they were back to normal. And then we actually call that the prodromal phase before the episode. And so if they have something kind of long and drawn out, and then sure, maybe it becomes a more severe episode. But if you capture that history, that usually means it's because of a primary psychotic disorder rather than a medical condition, physical health condition. Age at onset. So often, this is true for a lot of mental health disorders, including depression and anxiety, Often this is going to present itself in adolescence. And that's partly why I like working with adolescents, because often this is the first time that they're going to experience these conditions. And that is more, so adolescents or like, 20s, I would say below 30 for psychosis, that is more suggestive of a primary psychotic disorder like schizophrenia or bipolar disorder. If a person is having their psychosis experience later in life, especially, past age 50, I'm going to start thinking more of another cause, another physical health concern, rather than a primary psychotic disorder. Types of hallucinations. So seeing earlier different types, auditory hallucinations are classic for primary psychotic disorders. I'm not going to say it's impossible for them to see things. It's just lesser of the case. Often with a combination of those other things I told you, that suggest a medical, physical health cause, usually like feeling things and tasting things is more suggestive of a physical cause rather than a primary psychotic disorder. Family history. So family history of a psychotic disorder, more likely that this is a primary psychotic disorder for the person in front of you. Emergence of psychosis in general medical or an intensive care unit setting. Makes sense. If the psychosis only presented itself while they're being hospitalized or treated for something, likely it's that thing rather than a primary psychotic disorder. I mentioned already premorbid or prodromal symptoms. Substance-induced psychosis. So thinking through, a substance-induced psychosis will generally be limited to the time period during or soon after intoxication, withdrawal, or exposure to the substance, after which the person will return to their baseline. Diagnosis. So when I think through the diagnosis, I'm not going to go through every single condition and go through all the DSM criteria, because we don't have time for that, and it's something you can easily look up. I wanted to think through more like, what's my decision tree? What's my algorithm that I use when I have someone who's coming in for psychosis? How do I think through, what condition there is at play? So I actually like to think of it through timeline. So if it's been 1 day to less than 1 month, I'm thinking more brief psychotic disorder. Of course, if I'm seeing in the context of psychosis, I'm going to follow them and see how long the symptoms persist. And so some people actually do have episodes that short and don't have any other episodes, and that's brief psychotic disorder. 1 month to less than 6 months, I'm thinking about delusional disorder. A brief comment on delusional disorder. How it's different from other psychotic illnesses is the delusions are the most prominent feature. They may or may not have functional decline. And the hallucinations are minimal or just not there. Unlike schizophrenia, which I'll talk about in a second. And then there's schizophreniform. Schizophreniform, the way I think about it versus schizophrenia is it's under 6 months. And then if it's 6 months or more, I'm thinking schizophrenia. And schizophrenia is generally understood to be a lifelong condition. So once you're going more than 6 months of hallucinations, delusions, functional decline, it's gone more than 6 months and you have the diagnosis of schizophrenia, should be considered a lifelong condition. It doesn't mean that they will always have those symptoms. Hopefully they get good treatment. But treatment almost lifelong is really important. Mood symptoms predominate. So that what I first talk about is when the psychosis symptoms are most predominant. What about when mood symptoms predominate? And I'm highlighting this to say that it's not just schizophrenia, right? So there's also depression with psychotic features. So there can be people who a lot of us know what depression is. We understand what that is. Sometimes they might have a delusional component or a auditory hallucination component, but the mood is most predominant and the psychosis is not always there. And then bipolar disorder. Bipolar disorder, I can have a whole talk about bipolar disorder, one of the most misunderstood conditions. But I just want to highlight that with bipolar disorder, if I may, just briefly, they often have mood episodes, whether it's a depressive episode or a manic episode, manic being lots and lots of energy, very little need for sleep, talking fast, rapid thoughts, doing things they don't normally do. Often they can hear things and they can often have delusions. And then when both predominate, when you have both psychosis and mood, and they're both really predominant in the condition, then I'm thinking schizoaffective disorder. When I think of schizoaffective, I think of schizophrenia plus a mood disorder. So there's always psychosis at play with sometimes a superimposed mood episode. If it's depression without mania, then it's schizoaffective disorder with, wow, someone has to remind me. When they have manic symptoms, it would be plus bipolar. I guess it would be with depression. Anyway, schizoaffective, they can have depression superimposed, and then sometimes they can have the mania superimposed. But there's always a psychosis piece at play. It's one of those things where I'm going to wake up in the middle of the night and be like, that was the word I was going to say. Okay. So considerations for Muslim populations, how symptoms and illness are understood. So I have the pleasure of working with patients aged 14 to 35. I work at St. Mike's. We support people in Toronto East. And many of my patients, just like by virtue of working in Regent Park and the East End, but of course we're everywhere, Muslims are everywhere. But the populations I serve are like from immigrant populations, many of them are Muslim. And honestly, like it is, just as an aside, it has actually been like an unexpected like joy for me. I did not appreciate how many Muslim patients I would have working in this clinic. It has been very spiritually fulfilling for me. Like not only is it fulfilling for me helping people get better, that's for everybody, but then the added layer of supporting Muslim patients, a lot of the time they tell me it's the first time they've had a Muslim psychiatrist and they feel comfortable sharing with me how they experience their psychosis through a Muslim lens. So symptoms and illness and how they understand it. So commonly, now I want to, with the caveat that this is not true for all of my Muslim patients, but I'd say for ones where religion is important to them or a really important part of their identity, then this is commonly the case. So often, and it shouldn't be a surprise to you, often for them, the auditory hallucinations is perceived as jinn. Right, which makes sense because many of us are taught about jinn. It's a part of our faith, you know, and then there's an added layer of folklore from our own cultures, right? Like my family's from Afghanistan. When I was a kid, there's all these like scary stories of like jinn experiences. And we would like, that was our version of like having a flashlight, taking turns talking about our jinn experiences, right? And so it's not a shock that for a lot of people with psychotic illness, their brain is trying to find a way of understanding this experience that they're having. And for a lot of the time, again, they're like, this is my first time feeling comfortable disclosing this because I feel like a non-Muslim psychiatrist would not understand what I'm talking about. Yeah, I would say commonly for me, from the Muslim perspective, often it's the jinn component. Sometimes people believe that they are prophets. That's another piece, like God is speaking to them, giving them a message. I would say that's rare, but I have seen it. So yeah, so that's an important aspect when I think about Muslim populations. And then a more important part, I'd say, is how to approach treatment. So Nabiha right now is training with me. She has a couple of Muslim patients under my care that she's seeing directly, and I'm supervising her. Some of the things we talk about in supervision are, you know, the way that we convey to our Muslim patient, our young Muslim patient, about their psychosis. For them, especially if they see it from a Muslim perspective, and often they're telling us that they are turning to an imam or Muslim scholars or someone in the community, and you know, turning to prayer, turning to particular forms of dua, turning to particular forms of prayer and worship to try and ward off the jinn. Again, from them, from the perspective of this is jinn, not necessarily a mental illness. And from my own experience, having a loved one with psychosis, I've really taken a very gentle approach. I do not antagonize my patient in trying to convince them that this is a mental health disorder. I talk about it. I say it's very much a possibility in the way that I understand it, but that doesn't mean it has to be the way you understand it. Maybe we can find a middle ground. I support you in turning to prayer and turning to faith, you know, within reasons, because sometimes people are spending a lot of money on these things, actually. So just wanting to be careful about that. But yeah, like I'm very open to always tell them if your family wants to come, if you want to incorporate that faith-based leader in our appointments, I'm more than happy to, you know, and I hope you're open to the idea that this might be a mental health disorder. And I encourage you to also take a medication. Whatever the cause is, I don't really care. I just want you to do better. I want you to feel better. I want you to sleep better. I want your mood to improve. So can we work together for a multifaceted approach, both incorporating your faith and spiritual aspects while also accepting medicine and therapy? All right. So again, this is what I mean by corny photos. Like, why do I have this hand holding plants? I don't know. I like these slides, and PowerPoint provided it to me. Thank you so much. And if any of you know this loved one, please I realize I was trying to focus on our journey and less on him, but that's okay. I'm just asking, if you do know our loved one, just please respect his confidentiality and just really trying to focus on our experience and trying to support him. And yeah, my mom had actually mentioned one piece that I also wanted to add, which was that, yeah, he was one credit short of graduating from undergrad. And I feel like, again, if you're a family member yourself, like, you're going to hustle to do anything for your loved one, right? So like for me, I was just like emailing left, right, and center anywhere at U of T. I went to U of T for undergrad, so like reached out to old professors, and I was like, he's just one credit short, like, what can we do to make this happen? And fortunately, he was able to enroll, and it was like a 4th-year course, and it was so hard, and I had to help him out a lot, but he got through it, and he graduated, and it was such an exciting time for all of us. So I think we'll wrap up this section. I do have a couple more slides, so thank you so much to my mom. And just very quickly, just wanted to share with you a few helpful resources. So I mentioned the Institute for Advancements in Mental Health, formerly the SSO. They offer one-to-one support for families. They offer the Strengthening Families Together course, and they offer CBTP. The Family Navigation Project at Sunnybrook, this is not specific to psychosis. This is for any mental health condition. They support youth and their families. And if I understand correctly, you don't have to be a Sunnybrook patient for yourself. Just as long as you live in the GTA, you can sign up online. Access Point, that's another really important one. Some people approached me after the families talk, community talk on the last session, asking like, how do I get them help? So Access Point, I really, really recommend checking that website out. It is a centralized access point, literally, for mental health resources and addictions resources, including things like housing, employment, but also connecting them with psychiatrists and teams, such as the one that I work through at St. Mike's. We take mostly focusing on St. Mike's patients, but also people outside of St. Mike's through Access Point based on the location that they live. So again, it's not just for psychosis, but especially for psychosis. Especially, I should highlight that the Ontario has standards for supporting young people with psychotic illnesses. The ideal is to get them connected with a psychiatrist and a team within 2 weeks of the referral. Is that actually happening? No, but they're always trying their best to at least have a first point of contact in under a month of the referral being made. When I say referral, I don't actually mean doctor's referral. It's very, very liberal. It allows for self-referral, and it also allows for family members to refer as well. So please check that out. And these are my citations, and that is the end of the presentation. Thank you so much.